On-the-scene video coverage of TCT 2012 is supported by Pradaxa.
So the data that's been presented this morning is largely confirmatory, and it confirms what we learned from the earlier studies of Simplicity, which demonstrate an increasing benefit over time for lowering blood pressure in patients that have undergone renal denervation. That increasing benefit over time with renal denervation has not been associated with any safety problems.
Radiofrequency sympathetic ablation, which is what's being reported here, is a much needed, very effective, remarkably effective, and I've got to say remarkably safe.
My gut instinct is that it seems to work. I think the key question is in how many patients will this actually be able to work? Is this going to be something that works in resistant patients as well as patients that are not resistant? Are some of the non-hypertensive related effects that appear to be promising of this therapy, are those going to be realized as well? Right now, I think the market could be huge and the amount of patients that could be helped is also huge, but it may not be that that's the ultimate case.
This is controversial and I think very exciting, and that is that this is a treatment for essential hypertension, meaning a cure or a major deficit in blood pressure in patients with essential hypertension we've never seen before. The major problem with hypertension today is compliance, or the patient's ability to adhere to a medical regimen, which is extremely difficult over years, particularly when there are multiple medicines required. And so this treatment could markedly improve the control of hypertension over time in patients who now are facing 30 or 40 years of sustained medical therapy. If they can reduce their medicines or get off them, it could be a major, major benefit to our patients.
Hypertension medicines do work. Some of the combinations recently have been given FDA warnings, such as the Divan-Tecturna combination, particularly in diabetic patients, which I think is really a challenge. I can tell you, even in a practice like mine, that we've, in our overall practice, created a hypertension clinic with hypertension specialists because it really is a challenge. And patients often don't tolerate 4 and 5 drugs.
What kind of a blood pressure do you see that you should limit this therapy to right now?
Well, right now in the trial in the United States, a patient who would be eligible needs to have a blood pressure greater than 160 millimeters of mercury systolic. And remember, the standard definition of hypertension is anywhere from 130 to 140, depending on which criteria you use. So you have to have 160 despite being on 3 medicines that are already essentially maxed out, if you will.
Heart rate is a sympathetically driven function, and the procedure that we're performing is denervation of that sympathetic tract. So when heart rate falls, it indicates that we have successfully interrupted that sympathetic tract. There may be clinical benefits to denervation and slowing heart rate. Those remain to be measured and demonstrated, but they're a sign of efficacy of the procedure.
I think the concept of renal sympathetic denervation is here to stay. I think it's effective. We have to continue to try to make it safer. And the application for this is not just hypertension, which is rampant in our society. There are those that are already looking at this for an adjunctive treatment for heart failure as well, where sympathetic tone is increased.
Once safety is established and we're comfortable that the procedure is in fact safe in those with the worst form of hypertension, then I think you expand the indications as long as it's safe down to patients who have much less severe hypertension, but now you're treating them for compliance issues and for long-term control of blood pressure issues.
Based on the preliminary data, it does appear that the systolic blood pressure drops 30 millimeters of mercury, but that's still in a range. If it's 160 and it drops 30, it's still 130. So, and these are people already on medications. In terms of whether we can use it in people with less severe hypertension, that's something that needs to be a subject of future study.